be an effective endpoint for biologic therapy? Please, sir.
Okay, thanks. I really thank you for your kind invitation, and always when we come to any country in the Middle East, this is a very nice surprise for us to enjoy your very generous hospitality, so thank you for that. For those of you who are interested, my talk about MESA is today at 7 p.m. in the lobby of the hotel. Okay? Now I'm talking about mucosal healing as an effective endpoint for biologic therapy. And I have to start by saying that there are a few knowns and a lot of unknowns in this topic of mucosal healing. And the purpose for me this morning is to provide you with a summary of all the knowns, but also all the unknowns. And I fully agree with Dr. Federak when he said that we are not yet setting mucosal healing as a therapeutic objective. And I will try to summarize the evidence why I fully agree with Richard's statement. And I will summarize the evidence first. And there is uncontroversial association data showing that in ulcerative colitis, mucosal healing entails lower relapse rates, and also there is more recent data showing that the degree of healing influences the risk of relapse. And you see here data coming from the Act 1 and 2 studies, and these are the proportion of patients with sustained remission at week 30 according to the severity of the lesions at week 8. And you see that there is a very nice relationship, a progressively decreasing proportion of patients which sustain remission as the lesions were more severe. And you may also from this slide understand why usually mucosal healing is defined as a Mayo endoscopic subscore of 0 and 1, because there is a huge difference between 0 and 1 versus 2 plus 3, but still when you have 0, when you have a completely healed mucosa, your chances of continuing in remission are higher than even if you have only mild lesions. But is that enough? Is endoscopy enough? Could we look deeper into what's happening in the intestine at the cellular level? Well, if we do this, and this is a study from Canada, from Alan Bitton, and he analyzed a number of factors, and really the factor that entailed a higher risk for relapse was a histological change, where a persistent histological changes, basal plasmocytosis. This has been confirmed in a more recent study of Leuven, but for many years this has been the only study showing that really remaining histologic abnormalities are the best predictors of relapse in UC. So healing, and even histologic healing, is one of the main prognostic factors for the risk of relapse. What about Crohn's disease? Well, in Crohn's disease also we have data in which mucosal healing is associated with lower relapse rates, but data is more difficult to interpret for Crohn's disease in terms of the relationship between the degree of endoscopic or histologic healing and outcomes. And also, I think that as a first step in understanding this complicated picture, one should take into account some confounders, and one of the confounders is treatment. And I want to exemplify this with using only the results of 2 studies. This is the result of the EXTEND study. So far, the only completed study in which mucosal healing was the primary endpoint, and this was with using adalimumab. And you see here that when we look at the mucosa at week 12, and we separate the patients according to the severity of lesions, minus than 5 of the CES-CD score, or plus than 5, you see that those with clinical remission at week 52 were considerably higher in the ones that had a score lower than 5 at week 10 than those that had higher score than 5 at week 12. Sorry. But for those of you who are used to calculate the SESCD, you know that 5 is by no means complete mucosal healing. Okay? You can even have some ulcers in some segments, but still this cut-off point very nicely separated patients into those of high risk and low risk of sustained remission during the following year. Here we have another study. This is the study, the follow-up of the stop-up top-down study. And here patients are separated according to no lesion at all, SESCD of 0 versus any lesion, okay, 1 to 9. And you see that also the proportion of patients with sustained remission during the following 2 years, year 3 and 4, that was assessed at the end of year 2. So in the following 2 years, the proportion of patients are much higher in those with complete healing as compared to those who had any lesion. Okay, so the trend is the same. Achieving mucosal healing is a favorable outcome or predicts favorable outcome in terms of relapse risk, but there is a huge difference in the cutoff point between the two studies. There is also an important difference between the two studies. In the first study, an active drug is maintained, which is adalimumab. In the second study, the majority of the patients were not receiving anti-TNF therapy. So it might be, and this is one of the important points and maybe one of the important confounders, that when you maintain an effective therapy, you may allow persistence of some lesions, and that should not lead to treatment intensification per se by the mere presence of lesions. When you have no potent maintenance treatment and you find lesions, you might have to consider really intensifying treatment in these patients. So when you look at this, presence of concomitant maintenance treatment is one of the factors we should take into account. Well, another point that has been discussed is that in ulcerative colitis and Crohn's disease, mucosal healing is associated with lower hospitalization rates, lower surgery requirements, and again, only for UC, the degree of healing influences the risk of adverse outcomes. And you see here, this is a study from an Italian study from Sandro Ardisone, and it's an example of very nice and relevant clinical things you can do when you do your clinical practice very well organized. And here, he divided, those were patients finishing a course of steroids. He scoped the patients at 3 months after finishing steroids, and 3 groups of patients were identified. Those with clinical and endoscopic remission, those with in-clinical but no endoscopic remission, persistent lesions but asymptomatic patients, and those with no remission. And you see that for a number of outcomes, including relapse in the following 5 years, hospitalizations, need of immunosuppressants, and colectomy, there is a progressive increase in the need, in the adverse outcomes when you had no endoscopic remission, even if you had clinical remission. And for that, and the comparison between clinical but no endoscopic remission versus clinical and endoscopic remission, it is significant for all the 4 outcomes. That means that even if you are well, even if you have a patient without symptoms, the persistence of lesions will entail about outcome. And here, again, the degree of healing is influencing the surgery requirements. When we divide patients in the Act 2 and Act 1 studies between those who had a score of 0 and 1, nicely separate in terms of survival free of colectomy with those patients that had a score of 2 and 3. Again, 0 and 1 behave very closely as for the risk of relapse, and 2 and 3 have a much worse outcomes. In Crohn's disease, we have the same data. This is data from the Ibsen study. These authors assessed the state of the mucosa at 1 year after diagnosis, and those who did not have healing had a survival free of colectomy much lower than those who achieved mucosal healing, and that was irrespective of the concomitant treatment they were receiving at that time. But again, another study tells us that when you maintain treatment in Crohn's disease, probably this is highly protective against the development of complications, even if there are some lesions persisting. And this is the study of Leuven. Again, all this cohort of patients were maintained, or the majority, more than 90%, were maintained on anti-TNF therapy. And you see that those patients who are under anti-TNF therapy achieve complete healing, behave equally well than those who had still persistent lesions showing just an improvement. By contrast, those who had no response at all in terms of lesions had a much worse outcome, much higher requirements of surgery. So again, persistent lesions in Crohn's disease may be allowable, may not necessarily lead to treatment intensification, as long as patients are already under a potent treatment for maintenance. In ulcerative colitis, presence of inflammation and endoscopy or at histologic evaluation is associated with higher risk of dysplasia and cancer. This data has not been produced in Crohn's disease. I'm not saying it wouldn't be the same, just we have no data confirming this point in Crohn's disease. And I want to show you data of a couple of studies. In this study from Rutter, published in 2004, he looked at a number of predictors for colorectal dysplasia, and he found that either the colonoscopy inflammation score or the histologic inflammation score were the only significant predictors for the risk of neoplasia. And the odds ratio was 2 for colonic inflammation and 5 for histologic inflammation. It may be surprising that PSC did not reach statistical significance, but the study was not sufficiently powered to show the influence of that variable. And in another study, this is more recent, this study of Gupta concentrates on histology, and they collected the data of serial endoscopies performed in a screening program to a number of patients, and he did all type of analysis, and when he looked at the mean inflammation score of all colonoscopies, or he looked at the number of colonoscopies that had a mean inflammation score of more than 1, or either at the maximum inflammation score of any colonoscopy, all this, any of this was predictive of advanced neoplasia. So histologic score is even, in the previous study I showed you, it's even better than colonoscopy, and even if you look only at a few of the histological scores, this is a good predictor for the risk of neoplasia in any particular patient. And finally, does mucosal healing helps us in choosing our patients to withdraw the drugs? Well, again, Dr. Fedorak has told a bit about this, and I would say that in Crohn's disease, mucosal healing is just one of the predictors of relapse, okay? When sometimes talking with colleagues, their view is that, well, a patient that has been under anti-TNF therapy for 3 years is in relapse, they look at the mucosa, and if this is healed, then treatment is withdrawn. Well, you should pay more attention at other predictors, okay? Mucosal healing is just one, and for the case of TNF, and that does not predict the relapse, the risk of relapse in patients who are in corticosteroids or azathioprine treatment. And here is the STORI study. You see that these authors identified various predictors: male, gender, surgery, steroids, hemoglobin, white blood cells, CRP, clinical activity. And if you had less than 4, then your risk of surviving free of relapse upon stopping infliximab was high, but the predictor ability of presence of lesions was not better, for example, than that of CRP. So it's one predictor is not the definitive predictor that will tell us whether we can stop biologic therapy in a particular patient. And just to remind that in the case of steroids, this is a study in which patients that had finished a steroid course were scoped, and the proportion of those who relapsed was exactly the same in those who had endoscopic healing, the green line, or those who had still lesions in the purple line. And also for azathioprine, this is the study of Mark Lehmann of withdrawal of azathioprine. He didn't find a significant difference in patients who continued or not the drug over time, but presence of lesions was not predictive of relapse in any of the two groups. So for azathioprine, probably the safest approach is, as Dr. Fedorak said, just maintain the drug, but if for some reason you are thinking on withdrawing the drug because you have an old patient or you have a patient that may have adverse events, so it's looking at the presence of healing will not help us you to identify those at risk of relapse. So how important is mucosal healing to predict the curves or to take management decisions in IBD? We know of associations, of the association with the relapse rates, with hospitalization, with the need of surgery, with the risk of cancer, and particularly we know that histologic healing is associated with better outcomes in the aspects that have been analyzed. Mucosal healing predicts relapse after anti-TNF withdrawal, not after corticosteroids or azathioprine. But we have a lot of unknowns, and let me finish my talk by highlighting these unknowns. We still don't know which is the impact of achieving mucosal healing on long-term bowel damage. It is conceivable that there should be an influence, but this has not been shown. What is the best timing for endoscopic evaluation in the postoperative setting of Crohn's disease? We yet don't know. We usually perform this evaluation between month 6 and month 12, but we don't know if that should be even earlier than that. What is the impact of mucosal healing in the risk of colorectal cancer in Crohn's disease? No information. Whether sustained mucosal healing is required to change the course of the disease, or if we maintain effective therapy, even in the presence of lesions, we will be able to change the course of the disease. Again, another unknown. Should therapies be optimized to achieve mucosal healing or to avoid adverse outcomes in the absence of healing? What degree of mucosal healing is required to modify the disease course? And what is the impact of histologic healing in the course of Crohn's disease? So we need a lot more of information. We need a lot more of studies, and really I encourage you also to provide your contributions to this point. Thank you very much.